Maria Jenkins had been watching Dr. Michael Stevens work for 72 straight hours when she realized that his exhaustion was about to kill someone. The renowned cardiac surgeon hadn't left Metropolitan General Hospital since Monday morning, surviving on coffee, adrenaline, and the kind of stubborn pride that makes brilliant doctors believe they're invincible. It was now Thursday afternoon, and Maria could see what everyone else was refusing to acknowledge. Doctor! Stevens was no longer fit to operate, but in the hierarchy of medicine, suggesting that the chief of cardiac surgery should step away from a life-saving procedure wasn't just inappropriate, it was career suicide. Especially for a black nurse who'd already been labelled difficult for questioning protocols and advocating for patient safety over administrative convenience. Maria had been assigned to the cardiac intensive care unit 6 months earlier, specifically to work with Dr. Stevens's team. At 31, she brought 8 years of nursing experience and a reputation for catching details that others missed. She'd earned her position through exceptional clinical skills and an almost supernatural ability to anticipate complications before they became critical. Dr. Stevens was a legend at Metropolitan General. At 42, he'd performed more successful cardiac surgeries than any surgeon in the state. His techniques were taught in medical schools, his success rate was unmatched, and his dedication was absolute. When complex cases arrived from across the region, families specifically requested Dr. Stevens because they knew he would fight for their loved ones with everything he had. But that dedication was becoming dangerous. The crisis had started Monday morning when a multi-vehicle accident brought 5 critical patients to Metropolitan General's trauma bay. 2 required immediate cardiac surgery and Dr. Stevens had volunteered to handle both procedures back to back. What should have been a 12-hour day had stretched into 3 days. As complications arose, additional surgeries became necessary, and Dr. Stevens refused to hand off cases to other qualified surgeons. Dr. Stevens, Maria had said Tuesday evening as he finished his 2nd consecutive surgery. Perhaps, Doctor? Rodriguez could take the overnight cases? You've been here for over 30 hours. Stevens had looked at her with the kind of tired irritation that comes from being questioned when you're already pushed beyond your limits. Nurse Jenkins, Dr. Rodriguez isn't familiar with these specific cases. Continuity of care is essential for patient outcomes. It was a reasonable response, medically sound and professionally appropriate. But Maria noticed the slight tremor in his hands as he removed his surgical gloves, the way his usually precise movements had become just slightly less coordinated. She'd seen these signs before in residents during brutal rotations, but never in an attending physician, and never in someone responsible for such critical procedures. By Wednesday morning, Doctor. Stevens's exhaustion was becoming visible to everyone in the cardiac unit. His usually impeccable surgical notes contained minor errors, nothing medically dangerous, but inconsistencies that showed a mind operating under severe fatigue. During rounds, he occasionally paused mid-sentence, searching for words that normally came automatically. His legendary steady hands showed microscopic tremors that only someone watching closely would notice. But the medical hierarchy at Metropolitan General had a way of making inconvenient observations invisible. The residents were too intimidated to question Dr. Stevens's condition. The attending physicians assumed that if Stevens felt capable of operating, he must be fit to do so. Hospital administration was more concerned with managing the crisis than monitoring individual physician well-being. Maria found herself in the unique position of being both close enough to observe Stephen's deterioration and experienced enough to understand its implications. As his primary surgical nurse for the past 6 months, she knew his normal patterns better than anyone. She could see that his current state was far from normal and getting worse with each passing hour. The breaking point came Thursday afternoon when Dr. Stevens was scheduled to perform emergency surgery on Amanda Chen, a 34-year-old mother of 2 who'd suffered a massive heart attack. Chen's condition was critical but operable. With proper surgical precision, she had an excellent chance of full recovery. But the procedure required absolute focus, steady hands, and the kind of split-second decision-making that exhaustion compromises. Maria watched Dr. Stevens prepare for surgery with growing alarm. His hands were shaking noticeably now, and she'd observed him checking and rechecking surgical notes that he normally memorized instantly. Most concerning, during the pre-operative briefing, he'd confused Amanda Chen's case details with those of a patient from 2 days earlier, a mistake that could prove fatal if it carried into the operating room. "Dr. Stevens," Maria said as he scrubbed in, "perhaps we should wait for Dr. Martinez to arrive? I know she's familiar with this type of procedure." Stevens turned to face her, his eyes showing the kind of glazed focus that comes from extreme fatigue. "Nurse Jenkins, Mrs. Chen can't wait. Every minute we delay increases her risk of permanent cardiac damage." He was right about the urgency, but wrong about his capacity to handle it. Maria had reached the point where her professional obligations as a patient advocate were in direct conflict with the medical hierarchy that demanded deference to attending physicians. As they entered the operating room, Maria made a decision that would either save Amanda Chen's life or end her own career. She began documenting everything: Dr. Stephen's hand tremors, his confusion about case details, his delayed responses to standard surgical cues. If something went wrong, there would be a record of the warning signs everyone had chosen to ignore. The surgery began normally. Dr. Stevens' muscle memory and years of experience allowed him to perform the initial procedures with apparent competency. But as they progressed to the more delicate aspects of the cardiac repair, Maria watched his exhaustion manifest in ways that made her heart race with alarm. His hand tremors were affecting his precision. He paused longer between surgical steps, as if his brain was processing information more slowly than usual. Most critically, during a procedure that required connecting a bypass graft to the patient's coronary artery, Maria saw him hesitate, his scalpel poised over Amanda Chen's heart while he struggled to remember the next step. "Doctor," Maria said quietly, stepping closer to the surgical table, "the graft connection goes to the left anterior descending artery." Stevens looked up sharply. It was basic cardiac surgery knowledge, something he'd performed hundreds of times. The fact that he'd needed a reminder sent a chill through the operating room. "I know where it goes," Stevens snapped, but his voice lacked its usual authority. What happened next unfolded in slow motion. Dr. Stevens positioned his instruments to make the critical connection, the procedure that would restore blood flow to Amanda Chen's damaged heart. His hands were shaking more noticeably now, and perspiration was visible on his forehead despite the cool temperature of the operating room. As he began the delicate suturing, Maria watched in horror as his exhausted coordination failed him. The suture went too deep, nicking the arterial wall and causing immediate bleeding into the chest cavity. Not a fatal mistake, but one that could become critical if not corrected immediately. The operating room fell silent, except for the steady beep of monitors and the quiet alarm indicating Amanda Chen's dropping blood pressure. Dr. Stevens stared at the bleeding, his face pale with the realization of what had happened. His hands were shaking too badly to attempt the repair, and his exhausted mind seemed unable to process the next steps. "Suction," he said weakly, but couldn't hold the instrument steady. In that moment, Maria faced the decision that would define her career. She could call for Dr. Rodriguez, who was in another surgery and wouldn't be available for at least 45 minutes. She could wait for Dr. Stevens to regain his composure, risking Amanda Chen's life while blood pressure continued to drop. Or she could do something unprecedented in her 8-year nursing career. "Dr. Stevens," Maria said, her voice cutting through the controlled panic in the room, "you need to step back and let me guide you through the repair." The entire operating room turned to stare at her. Stevens looked up from his trembling hands, confusion and anger warring in his exhausted eyes. "What did you say?" he asked. "I've assisted with this exact complication 12 times in the past 6 months, Maria explained, moving closer to the table. "I know the repair technique, and right now I'm the steadiest pair of hands in this room." It was an unprecedented breach of medical hierarchy. Nurses don't instruct surgeons during procedures. They don't take command in operating rooms. They don't tell attending physicians to step aside. But Amanda Chen was dying, and Maria was the only person in the room with both the knowledge to guide the repair and the clarity of mind to execute it. Dr. Stevens looked at the monitors, then at his own shaking hands, then back at Maria. The decision took less than 5 seconds. "Tell me what to do," he said. What followed was the most intense 20 minutes of Maria's career. Standing at Dr. Stevens's shoulder, she guided him through a repair technique that required absolute precision and perfect timing. "The bleeding is coming from a small tear in the arterial wall," Maria explained, her voice steady despite the enormity of what she was doing. "You need to place a purse-string suture around the tear to control the bleeding." Stevens followed her instructions, his hands steadier now that he had clear direction rather than trying to navigate exhausted decision-making. "Good," Maria continued. "Now you'll need to place the sutures carefully. The artery is under high pressure, so each stitch needs to be precise." For 20 minutes, Maria became the brain-guiding doctor. Stevens' hands, her months of observation, her detailed understanding of cardiac procedures, and her clear-headed thinking under pressure combined to keep Amanda Chen alive. "Last suture," Maria said as Stevens completed the repair. "Increase the blood pressure gradually and check for leaks." The repair held. The bleeding stopped. Amanda Chen's blood pressure stabilized. The operating room erupted in quiet relief, but all eyes remained on Maria, who had just demonstrated that sometimes the most knowledgeable person in the room isn't the one with the highest title. As they completed the surgery and Amanda Chen was moved to recovery, Dr. Stevens finally acknowledged what everyone had witnessed, but no one had wanted to address. "I need to speak with administration immediately," he said quietly, "and someone needs to call Dr. Rodriguez to take over my remaining cases." The aftermath of that surgery changed everything at Metropolitan General. Dr. Stevens, after receiving proper rest and medical evaluation, publicly acknowledged that Maria's intervention had saved not just Amanda Chen's life, but potentially his own career. Nurse Jenkins demonstrated something we sometimes forget in the pressure of medicine, Stevens announced during the monthly cardiac department meeting. That patient safety must always take precedence over hierarchy, and that the courage to speak up when something is wrong is exactly what we should expect from every healthcare professional. The hospital implemented new protocols for monitoring physician fatigue and mandatory rest periods for surgeons working extended hours. Maria's actions sparked a hospital-wide conversation about creating environments where staff could raise safety concerns without fear of retaliation. But the most meaningful recognition came from Amanda Chen herself. When she was discharged 2 weeks later, she sought out Maria specifically. "The doctors told me what happened in that operating room," Chen said, tears in her eyes. "They said you saved my life by speaking up when no one else would." Maria smiled, thinking about the journey that had brought her to that moment. "I just did what any good nurse should do. I put the patient first." As Amanda Chen walked out of Metropolitan General with her family, Maria reflected on what she'd learned. In medicine, being underestimated isn't always a disadvantage. Sometimes it's the perfect position from which to prove that expertise comes in many forms, and that the most important voice in any room is often the one everyone assumes they can ignore. Dr. Stevens returned to surgery after a mandatory rest period, but with a new appreciation for collaborative decision-making and input from nursing staff. The cardiac surgery department implemented protocols requiring input from all team members when patient safety concerns arise. Maria Jenkins had proven that in medicine, the title on your coat matters less than the knowledge in your head and the courage to use it when lives hang in the balance. But perhaps most importantly, she'd learned that sometimes the most powerful position in any room is the one where everyone underestimates you, because that's when you have the freedom to exceed every expectation they never bothered to set. Amanda Chen lived to see her children grow up, all because a nurse refused to stay silent when she saw danger that others were too tired, too intimidated, or too invested in hierarchy to acknowledge. And at Metropolitan General Hospital, they never forgot the lesson Maria Jenkins taught them: that in medicine, no protocol should ever silence the voice that might save a life. Where are you watching from today? Have you ever noticed something dangerous that others were ignoring? Share your experiences in the comments below. Remember, in any field, the most important observations often come from the people others overlook. And sometimes being underestimated is exactly the advantage you need to prove that expertise comes in forms that can't be taught. Observation, courage, and the refusal to let hierarchy override safety.